Right. Howdy. Howdy. So today we have Dr. Karen Basen-Engquist. She received her Bachelor's of Arts in Psychology from St. Olaf College in Minnesota, her Ph.D. in Psychology from the University of Texas, and her Master's of Public Health from the University of Texas School of Public Health. So she's sort of a native of Texas at this point. She currently works as a professor in the Department of Behavioral Science at the University of Texas M.D. Anderson Cancer Center. She also serves as the director for the Center for Energy, Balance, and Cancer Prevention and Survivorship at the University of Texas M.D. Anderson Cancer Center. And she serves as an adjunct professor at the University of Texas School of Public Health and Rice University. In 2015, she was awarded the Provost Distinguished Research Faculty Mentor Award, the M.D. Anderson Margaret and James Elkins Junior Faculty Achievement Award in Cancer Prevention, and was a nominee for the Robert M. Chamberlain Distinguished Mentor Award. Today, she'll speak to us about obesity and endometrial cancer prevention and survivorship. So please join me in welcoming Dr. Karen Basen-Engquist.
Well, thanks so much. I want to thank Dr. Chapkin for inviting me to come talk to you today. It's always good to come down to Texas A&M and learn a little bit more about nutrition than I learned before, because I really don't know that much about nutrition. So I do most of my work in, well, first of all, in behavior change, and in looking at quality of life of people with cancer and people at risk for cancer, and then also trying to figure out how to help them improve their quality of life through changing their health behavior. So doing things like exercising, weight management, and some, as part of weight management, we address nutrition, but I'm always fascinated by some of the new work in the science of nutrition. So I'm going to talk a little bit about endometrial cancer survivors and also endometrial cancer prevention, which is something, kind of one of those cancers we don't always hear a lot about. We hear a lot about breast cancer, prostate cancer, colorectal cancer, but endometrial cancer is a little kind of understudied, I think. I need to use these keys. Okay, so, but first I'm going to talk about cancer survivors. So this slide sort of tells you a little bit about why I'm interested in the area of cancer survivors as a population to work with. So this is the estimated number of cancer survivors in the U.S. Right now we're at about 14.5 million cancer survivors, and we're projected to go much, much higher than that in the future years. So 14.5 million, does anybody have an idea of what percentage of the U.S. population that is? Anyone want to guess? Nobody wants to guess.
3%.
What? 3. Pretty good guess. Any other guesses? Nobody's gonna just try. 4. Somebody's, 8%. 8. Okay, so we're kind of surrounding it. Who said 4? That was the closest. So it's about 4.5%. So that means that if this room were full of a age diverse group, which obviously it's not, but if we had sort of a cross section of ages here, that means that 1 or 2 people in this room would be cancer survivors. So 4.5% of the population, we're getting into some high numbers, and this is a group that's not only at risk for kind of the chronic problems of that result from cancer and cancer treatment, but also they're at risk for other chronic diseases because of the risk factors they brought into their diagnosis of cancer. So about 12 to 14 years ago, the National Cancer Institute established an Office of Cancer Survivorship to try to increase research on cancer survivors, because it was kind of recognized that pediatric cancer survivors had a lot of issues. Children who are diagnosed with cancer often, have these they get really aggressive therapy, right? Because this is a child with cancer with many years of life. And so they do very aggressive treatments. And they were finding that some of these really aggressive treatments were having some quite serious effects for the children long term, in terms of sort of their cognitive functioning, their cardiovascular health, all sorts of things. And so it was really, that was kind of a going area of research, but nobody was paying much attention to survivors of adult cancers, so adult onset cancers. And so the NCI started funding more research in this area and also doing more public outreach and education in the area of cancer survivorship. And a lot of that research that was funded dealt with physical activity, exercise, diet, obesity, treatment issues in the cancer survivor population, because these behaviors are related to the incidence of cancer and to the quality of life of the individuals. Sorry, I keep using the wrong thing here. So, and a lot of that research was done on breast cancer survivors. So this is a breakdown of the female cancer survivors by site in the U.S. So you can see why a lot of the work was done on breast cancer survivors, right? That's the blue slice of the pie there, which is a large number. So it's always easier to do research in a population where you have large numbers. Whereas some of these other cancers, like the corpus uterus is endometrial cancer, and colorectal cancer, we have about 8% of the survivors. Those are also obesity-related cancers where the survivors might benefit from some of these interventions we were interested in. So I started some work in endometrial cancer. Just to talk a little bit about it, I want to just introduce you to endometrial cancer. So endometrial cancer is the most common gynecologic cancer. You hear a lot about ovarian cancer because it's such a severe diagnosis, has a really poor prognosis, but endometrial cancer is actually diagnosed in about twice as many women. So it's diagnosed in about 40,000 women a year. It's often diagnosed at a very early stage and it's highly curable. So that's the good news. So it's diagnosed in older women. Postmenopausal bleeding is an early symptom of the disease that comes up. The woman goes to her doctor, she's diagnosed, and it's treated fairly early. So it has a fairly high cure rate. And as a result, we have a lot of endometrial cancer survivors. So 40,000 diagnosed a year, but we have about 608 endometrial cancer survivors in the US. So what are the kind of risk factors that are driving endometrial cancer? Well, obesity is a big one. So of all the cancers, endometrial cancer kind of has the strongest relationship with obesity. So these are data from a meta-analysis of obesity, the relationship between obesity and cancer incidence. And you see endometrial cancer. So this line indicates no increased risk with obesity, and the boxes to the right show that those cancers have, there's increased risk of those cancers with obesity. And so endometrium, you see up here at the top, is the one that's the most to the right. So for every 5 kilograms per meter squared, you have about a 50 to 60% increase in the risk of endometrial cancer. Obesity is also related to endometrial cancer mortality. You can see that that's true for all cancers here. These are cancers in women, particularly in women, we see this. But endometrial cancer, there's an even stronger relationship with mortality. And so another kind of interesting natural experiment in terms of obesity and cancer that's been kind of emerging over the past 10 years. Can anybody think about what this might be in terms of how obesity relates, and weight loss specifically, relates to cancer risk? What's kind of a fairly new development in terms of weight loss in the past 10 to 15 years that's growing? Huh?
Surgery.
Surgery, right. So bariatric surgery. So this is from a study of about almost 10,000 individuals in Utah who had gastric bypass surgery, matched to adults with a similar BMI and as well as age and gender in the driver's license registry in Utah, and followed, with a follow-up time post-surgery of about 12.5 years. So they saw a significant reduction in the risk for all cancers, as well as obesity-related cancers only and cancers in women. So when they looked at individual cancer sites, because that's the next question that comes up, okay, how does weight loss relate to different kinds of cancer. Endometrial cancer is the only individual cancer site where there was a significant relationship. So, for a lot of those cancers, it probably was a sample size issue, even with 10,000 people. But endometrial cancer, we did see a significant relation. I said we, this is not my study, but the authors saw a decreased risk, of endometrial cancer after bariatric surgery. So this is, and it's quite a substantial reduction in risk with a hazard ratio of about 0.22. So obesity develops, it can increase the risk of endometrial cancer. That doesn't really answer the question for us of whether weight loss would decrease that risk, whether you can kind of reverse the risk. But the bariatric surgery studies are starting to answer that question for us. Now, these are many of these studies are by nature observational. We don't have a lot of randomized studies in this area, but they do provide a pretty strong indication that weight loss could benefit endometrial cancer survivors and people at risk. So the American Institute of Cancer Research did one of their continuous update reports a few years ago. Who's familiar with the American Institute of Cancer Research? I know Dr. Chapkin is because he reviews for them. So a few people.
I send them all the newsletters.
Oh, good.
Does anyone read them?
Start reading those newsletters. They're very interesting. So they work together with the World Cancer Research Fund to do continuous updates of the literature on the relationship between obesity, nutrition, physical activity, kind of different food patterns, eating patterns, and the risk of cancer. And they've also recently published one looking at it specifically in breast cancer survivors. So they did one a few years ago, a continuous update project on endometrial cancer, and did find, not surprisingly, given the data that I've just been showing you, that body fatness increases the risk from endometrial cancer, but also found some interesting kind of probable relationships. So physical activity tends to be strongly related to decreased risk of endometrial cancer. Coffee, interestingly, increased consumption of coffee decreases the risk of endometrial cancer, probably has something to do with insulin, and I'm sure many of you could describe that much better than I could. Also, the glycemic load of the diet increases the risk. A high glycemic load in the diet increases the risk of endometrial cancer. So the physical activity is of interest here because the studies included recreational, occupational, transportation activity, and also sitting behavior is kind of emerging as a risk factor for endometrial cancer. So this isn't true in all the cancers that are associated with physical activity, but you may have become aware of some of the literature around sedentary lifestyle and too much sitting as a risk factor, even for people who are doing some exercise. If you go do your 30 minutes and then you sit for 8 hours, then you go home and sit and watch TV some more. That you have an increased health risk as compared to someone who moves around more during the day. So sitting behavior does seem to have an increase. It does seem to increase the risk of endometrial cancer, although that's really kind of an emerging area of study that we don't know a lot about yet. So I first started doing some work in endometrial cancer because the National Cancer Institute had requests for applications to study physical activity just in any population, but they were really interested in sort of the behavioral mechanisms of physical activity adoption and maintenance. So, some of the studies that were funded under this RFA dealt with pregnant women, some were doing this. I think all the studies were adults. Some were doing it in, middle-aged people who'd had a negative stress test, so they were referred to a stress test for some problem or symptom, and it was negative. But they wanted to test whether this was kind of a teachable moment for the individuals to start exercising. So we decided to do some work in endometrial cancer. Why? Well, part of the reason is most survivors are obese. That's a risk factor. So most of them are obese. Most of them are physically inactive. And even though they have a high survival rate from their cancer, they have a shortened lifespan because of all their risk of other chronic diseases. So they have very high risk of diabetes, high risk of hypertension, cardiovascular disease, poor lipid profiles, and so forth. So we argued that this was a good population to look at in terms of investigating behavior change, and that it was, again, kind of the teachable moment idea, that this is a group of people, they've been recently diagnosed with an obesity-related condition, and perhaps this would provide sort of an impetus to change for them. So this particular study was, our goal was to look at some of the mechanisms of exercise adherence in the group. And we recruited early stage survivors of endometrial cancer. They had to have completed treatment for at least 6 months, because we didn't want to get people who were kind of, might have some complications from surgery or things like that with exercise. But we followed them, we gave everybody an exercise intervention and then followed them for 6 months to try to identify what was it that would determine whether they continued exercising. And again, the exercising here is fairly modest. We just wanted them to increase walking. The goal was to get them to 150 minutes of moderate intensity walking in the week, but we started with them wherever they were. And some of them started with, 5 minutes a day, 3 times a week, so it was starting very slow, and we gradually increased it. So just kind of thinking about the rationale for this, we did some surveys, and other people have done surveys of endometrial cancer and other gynecologic cancer survivors, and found that there's really a pretty low percentage of them that are meeting exercise guidelines. And of course, this is by self-report. If we, just as you have with issues in diet with self-report, we also have issues with self-report and physical activity. People usually report more activity than they're actually doing. So we can expect these numbers are a little bit lower even than this. And we also saw, and I mentioned this in terms of the rationale, in one of our pilot studies, we did see that they had kind of an elevated risk profile in terms of some of their metabolic risk factors. So there was a trend towards kind of poorer cardiorespiratory fitness. They had higher systolic blood pressure than a healthy group of women, more hypertension, of course, a higher BMI. And these women were all matched on physical activity, but not BMI. Waist to hip ratio was higher. So, there's a strong rationale for sort of moving forward and helping them increase their physical activity. So what did we do? This is the intervention that we provided to them. So again, we wanted to, we recognized that the probably, a kind of standard supervised exercise intervention wouldn't really answer our question appropriately, first of all, and also might not be acceptable to the population. So this was really a home-based program. The main modality, as I mentioned, was moderate intensity walking, with the goal of getting them up to about 30 minutes a day on most days of the week. We supported that with telephone counseling that started out weekly and for the first couple of months, and then gradually tapered off over time. And it lasted, 15 to 20 minutes. Some people like to talk a lot. Some people got on the phone and got off. They didn't elaborate a lot. But that was an opportunity for a coach, and this was generally kind of master's trained health educator, to provide some individualized feedback, help them with some problem solving, address motivational factors, and so forth. The main problem we had with this is what happens. So if they have motivational factors, what's the first thing that kind of happens, you think? Is someone's motivation to be physically active is sort of flagging?
They drop out of the study.
Yeah, well, they stop answering your phone calls anyway. Sometimes they would come back for assessments, but we sometimes, you have a hard time in these remote sessions to bring those people back in. with the motivational counseling. So it was important for us to set up create a setting where it was very accepting of setbacks and lapses and so forth, and try to not, we didn't want the situation where people felt really alienated if they were having trouble meeting their physical activity goals. They also received some print materials, kind of self-regulatory skills that taught things like goal setting, rewarding yourself for goals, identifying sources of social support for the behavior change. And the second thing that was in these print materials were role model stories. So this is kind of a important part of social cognitive theory, which I'm going to talk about in a minute, but the idea that there are people who are similar to you who are making this change. And, even though they might be encountering some barriers, here's how they solved those problems and pushed through and were able to be physically active. So this is something we use fairly consistently in our materials, in our interventions, is stories about other people making change as kind of a way for people to relate. And it's also a little bit more interesting. You can tell somebody, so, if you are feeling fatigued, and having a hard time, and fatigue is, of course, a big problem for many cancer survivors. So if you're fatigued, having a hard time getting yourself motivated to exercise, here are the 3 things you can do to help overcome that. So you could write that out, or you could tell the stories, and the storytelling, which would you rather read, right? So the stories are much more interesting, much more engaging way to convey the content. And they also all receive pedometers. These days we're using, the electronic things, Fitbits and so forth. But this is a couple years ago now, just old-fashioned, cheap, not too cheap, but pretty cheap pedometers. So this is a little bit of information about our sample. They were a little bit younger than the average age that endometrial cancer is usually diagnosed at, which, if you remember, a previous slide was about 61. So our sample was about 57. Probably has to do with MD Anderson as a tertiary care center. So, in a tertiary care center, you don't necessarily get a cross section of people diagnosed with a particular cancer, particularly a common cancer like endometrial. You tend to get the more unusual cases. So probably, if you were a 65-year-old woman with early stage gynecologic endometrial cancer at your gynecologist, you might be much more likely to be treated in the community. There might not be a need to say, we need to really refer you to MD Anderson because this is really a rare case. It's fairly common. It's a fairly standard routine treatment. We can do this in the community. But if you're a 40-year-old who has endometrial cancer, that's a little bit more unusual. So you might be more likely to be referred to MD Anderson. So that's probably why our age is a little bit younger. And we did have, somebody as young as 25 in the sample, which is quite unusual. Mostly white. Endometrial cancer does tend to be diagnosed more frequently in white women, probably because there's also an association with parity, that a later age of fewer children and later age at first birth are also related to an increased risk of cancer, and fairly well educated. I think, when you get to the BMI, you do see that the sample is quite heavy. So these are all endometrial cancer survivors who are selected because they're physically inactive. So they weren't meeting the recommendations for physical activity of 150 minutes a week that we were aiming for, but they weren't pre-selected for BMI. And I will say there were very few people who screened out because they were too physically active. Maybe 10 or 15% of the people we approached. So you see that only about 15% of the sample had a normal BMI. And about 21% were overweight, and the remainder were obese, various categories. So it's quite a heavy group. They were about 2 years from diagnosis, and were fairly early stage, but quite a few comorbidities. On average, 3 comorbid conditions, with hypertension being the most common. And probably one of the biggest challenges we had is that we did, so it was a home-based exercise intervention. So with very moderate intensity exercise, something that most doctors would recommend for a patient with hypertension. But we also did cardiorespiratory fitness testing at each of the assessments. And that was a bit of a challenge because, if you bring in people with hypertension, it's not always, the exercise testing is not always real straightforward. And we sometimes had we didn't have any serious events, but we had several people in that process. I sort of felt like I was doing a cardiac screening service for a while because the cardiologist would look at the EKG and say, okay, before we start them on the exercise, they need a workup. So, it was a little bit challenging. So looking at the, moving to the effects of the program, just in terms of what kind of changes occurred in terms of their health and quality of life, we did see a number of positive changes. And we were interested both, in seeing those positive pre to post changes. Like I said, this wasn't a randomized trial and this wasn't the primary aim of the trial to look at this, but we certainly hoped that people would improve in quality of life. And we also were interested in seeing whether the obese participants had the same level of benefit as the non-obese participants. So we saw improvements in all of these different variables. So they did increase their minutes of exercise, thank goodness. So that's good. Saw some improvements in systolic blood pressure, although, again, some of that could have been due to, looking at the results of the exercise test and some of them getting sent to the doctor to, get things better managed. So it might not be only the exercise. We can't rule that out. And then a lot of improvements in self-reported quality of life. So improved physical functioning, improved vitality, better mental health, fewer cognitive problems, fewer sexual problems, interestingly, and less distress about recurrence and things like that. In looking at the differences between the obese and the non-obese participants, we found that the women with obesity had, at baseline, had lower fitness, higher blood pressure, poor quality of life, especially in some of the physical areas at baseline. So they did have poor quality of life, but we didn't see any significant interaction between the assessment point and obesity status. So there was no evidence that the program worked better or less well for women who were obese. So that's really a good news story, right? Some people would say like this patient is just too overweight to get any benefit from exercise. Well, we didn't find any evidence of that. So we saw similar improvements for both the groups. So this is kind of an example of the patterns that we saw. So this is the example. One pattern we saw is, like I mentioned, there would be differences at baseline between the obese and the non-obese groups. So this is from the SF-36, a quality of life questionnaire, subscales measuring their physical functioning. So there are questions like, how do you have any trouble, walking up a flight of stairs, walking a block, walking a mile, and so forth. And a higher score is better. We see that at baseline, the non-obese individuals have a better physical functioning, and it improves over time. Obese individuals have a poorer physical functioning, but it also improves over time to an equal extent. And this is an example where they were really similar at baseline and made similar improvements. So both groups showed a reduction in cognitive problems over time and reductions in stress over time. So I think that's a kind of a good news story in terms of recommending physical activity for obese individuals, at least in this particular population. But as I mentioned, that wasn't the main aim of the study. What we were really interested in as behavioral scientists is kind of trying to tease out, like, what is it that makes one person really adhere to that recommendation versus another person kind of flag in their motivation and drop out. And so we used a model based on Bandura's social cognitive theory to look at the adoption and maintenance of exercise behavior. So kind of a couple of the important constructs in this theory are self-efficacy. So self-efficacy is your confidence that you can engage in the behavior. And in this case, we looked at it both from the standpoint of sort of your confidence that you could actually physically do the exercise, that you could walk for 5 minutes, for 10 minutes, for 15 minutes without stopping, and also confidence for being able to maintain an exercise program in the face of barriers. So how confident are you can do the recommended exercise even if it's hot outside? Actually, the scale we originally used was developed in Rhode Island, and they asked how confident you are that you can exercise even if it's snowing outside. So we had to change the question because almost all these women lived in Houston. So self-efficacy along with outcome expectations are expected to influence exercise adherence. So outcome expectations are, as the name implies, your beliefs, a person's beliefs about the benefits or harms they anticipate from exercise. So do they think that exercise is going to give them more energy, help them lose weight, make them tired, cause pain? Do they think it's going to be boring? The kind of balance of those factors also is hypothesized to predict exercise adherence. In addition, we were interested in some of those influences on self-efficacy. So Bandura suggests that somatic sensations and affect, so how you feel while you're doing the activity, influences your perceptions of self-efficacy. So if you feel like horribly out of breath and just exhausted during exercise, it's going to negatively affect your self-efficacy. Being able to do it successfully, having a mastery experience increases your self-efficacy. Modeling increases your self-efficacy. Remember those role model stories, and support for activity. So we wanted to look at these things in a really naturalistic way. So we used a method called ecological momentary assessment. So in traditional behavioral research, we do questionnaires, and you'll answer a questionnaire about your, confidence that you can exercise when it's snowing outside, or other things. And then we look at how that predicts behavior over time, or sometimes how that's related to cross-sectionally to behavior. But ecological momentary assessment tries to get at these perceptions and beliefs and feelings in real time as they occur in the environment. So people carry around, and these days we would use cell phones. At that time we were using more of a PDA sort of device that would prompt them at various times of the day to answer questions. So and this was happening during this home-based assessment period that you see here. So in the morning they received a prompt to answer some questions about self-efficacy and outcome expectations. They did random assessments of somatic sensations during the day. And also, when they exercised, they entered information about their exercise. In the evening, we also asked again about exercise because we were concerned that we might lose some information, that people might forget. And they also were accelerometers during this time, so we could look at how active they actually were. So what did we find when we kind of looked at this real-time measurement of self-efficacy on a daily basis? And how it correlated with behavior. So we found that self-efficacy was very strongly related to how much exercise they did that day. So a 1-point increase in our self-efficacy scale, which ranged from 1 to 5, was associated with an increase of about 6 minutes of exercise. And in another model where we looked at outcome expectations, we also saw a relationship between the positive outcome expectations and the minutes of activity done that day. So if you woke up in the morning and you thought, hey, if I exercise today, I am going to feel so good, you were more likely to exercise for longer that day. But we did not see a relationship with negative outcome expectations. So that was interesting. It sort of tells you that maybe emphasizing the positive is important. But when we put both self-efficacy and outcome expectations in the same model, self-efficacy stayed significant, but the positive outcome expectations was no longer significant. So self-efficacy sort of dominated there. And that turns out to be a very robust effect. So we looked at it in different ways to try to see if we could make that effect go away. So we used only accelerometer minutes as the dependent variable. It was still significant. If we dichotomized it into, this person exercised that day or didn't exercise that day, was significant. If we only include days on which people exercised, it was still related to the duration of activity. And here, this is a graph of the slope for each individual of the relationship between self-efficacy measured in the morning and their minutes of exercise. And you can see for all of the individuals, it's in a positive direction. So it appears to be a pretty robust predictor. We also looked at it longitudinally in terms of the more traditional questionnaires. And we saw that, so we're looking again at a baseline measure of self-efficacy and how it predicted exercise minutes 2 months later, and then looked at the 2-month self-efficacy and how that predicted exercise 4 months later. And we saw that when we, in our lab assessment, when we measured self-efficacy as a questionnaire, that we also saw that exercise self-efficacy, but not that barrier self-efficacy, predicted the minutes of exercise at the next time point. So just kind of delving in a little bit to like, well, what's driving self-efficacy then? How do we increase people's self-efficacy and make them more confident? So this comes from a small pilot study done by one of my postdocs a few years ago. And what happened is he brought people in for an exercise test, for a submaximal exercise test in the lab, and measured their self-efficacy as well as their somatic sensations, sort of how they were feeling physically during exercise. And then, before and after exercise. And then he had them fill out diaries for 6 days on the amount of activity they did. So it was a very, short-term study. But, and this were a small sample of endometrial cancer survivors and a small sample of healthy women who were the controls. And interestingly, you saw that for the cancer survivors, there was a significant increase in self-efficacy from before to after the exercise test. So just doing the exercise test increased their efficacy. Did not see that change as significant in the controls. And looking at the predictors of that post-exercise self-efficacy, for the survivors, how they felt initially, as well as their somatic sensations during the exercise test, were related to the post-exercise self-efficacy. But for the controls, and we had the same sort of thing, but it was not significant. So that change in and the interesting thing, so you might say, well, like how important is that change in self-efficacy for anything? It's just an exercise test. Well, it did positively predict the minutes of exercise in the following 6 days. So even those small changes, those small experiences can affect self-efficacy. So this is a more complex modeling that a second postdoc or later postdoc did of the data from the full study. And I think, so just to kind of sort this out, he also found that the somatic sensations here related to self-efficacy at a later time point, which related to physical activity minutes that were done at the 6-month time point. We're not sure why this took a few months to show up, but and partly it's because there's a lot of variables in this model. But it was, I think it provides kind of some interesting hypotheses. What we think is that maybe this is not a very healthy population, and that their physical, how they're feeling physically is really, if they're not feeling well, that they're going to have less confidence. So if they're having, they're out of breath, short of breath, affects their confidence, affects the likelihood that they'll continue to exercise. So, a couple of the take-homes that we took from this, one is it was very interesting for us to see that not just questionnaire measured self-efficacy, but that kind of those daily changes in self-efficacy and perhaps outcome expectations had an impact on how much activity people did. This provides a stronger kind of cause and effect relationship than we can usually get, certainly in a cross-sectional study. But it also indicates that if you could do some sort of real-time intervention that to increase people's self-efficacy, maybe you could get them to be more physically active. If you got a little text message on your phone that was kind of tailored to you to help increase your sense of efficacy, maybe that would help you exercise more that day. So we are, doing some work along those lines and looking at developing kind of the smartphone apps for cancer survivors to try to provide that messaging. We also realized, in the course of doing this trial, what do you think the main reason is that most women participated in this trial? Weight loss. Yeah, they wanted to lose weight. So those of you who are in nutrition, is exercising a good way to lose weight? So it helps. Is it exercise alone a good way to lose weight? No. So, if you really want to help people with substantial weight loss, you need to make some dietary changes too, right? So we're working on that now. We're doing some pilot testing of a tailored weight management program for endometrial cancer survivors that we hope to do on a more national scale if we can, get the right funding to pull it together. So just in the last few minutes, that's some of my work in the area, but I just wanted to highlight some areas that I think are important for this population and for other cancer survivors and for, people in general who are at risk of chronic diseases. So, again, going back to the AICR, they did a survey a few years ago that showed that only about 52%, and only a little over than half of the American public is even aware that there's a link between obesity and cancer. Right, so we've got 10 cancers that are significantly associated with obesity, and half the country is not even aware of that. So the rest of this data is from a survey of gynecology patients I think this was done at UNC. And they are just kind of comparing awareness of the risks of obesity in the general gynecology patients, comparing them to gynecology patients who have endometrial cancer or endometrial hyperplasia, which is sort of a precursor lesion for endometrial cancer. The lighter bars are the ones that have cancer or hyperplasia. And they were sort of encouraged by this idea that the women with endometrial cancer or hyperplasia had higher awareness of the link between obesity and endometrial cancer, but you see it's still only about 50%. So it kind of mirrors the national average. The general gynecology patients, even lower awareness of that. So it seems clear this isn't a message that gynecologists are talking about very much. They also didn't really have a very high awareness of breast cancer being linked to obesity. They knew more about hypertension and heart disease. So the cardiovascular folks are doing a better job than the cancer folks are getting this message across. And then this is a second survey that I found. These are both very recently published studies. Again, kind of small, but I think they point out an important issue about cancer doctors talking to patients. So in the survey of endometrial cancer survivors, just about 108, they were asked about their whether they'd been counseled for weight loss by either their primary care provider or their gynecologic oncologist, and also whether they'd had any weight loss attempts. And you can see that they were much more likely to be counseled by their primary care provider. And of course, we say counseling, but I think any of you who have been to the doctor lately probably recognize that doctors don't do a lot of counseling, but this is probably more like the physician saying, you should really think about losing some weight. So that's a good start. And we don't really expect that most primary care providers or gynecologic oncologists are going to spend lots of time counseling, but I think it's a very important first step to have them address the issue and raise the issue. So, about half of the patients said they'd had counseling from their PCP, but only about 32% had a recommendation to lose weight from their gynecologic oncologist. Much smaller, 23% had counseling about diet. About 34% had a doctor say, or gynecologic oncologist say, you should be more physically active. When they looked at how this related to the weight loss attempts, about 56% of those whose PCP told them they should think about losing weight, about 56% went ahead and tried to do that. So, but if they were counseled for weight loss by the gynecologic oncologist, 100% made a weight loss attempt. Now, we all know, any of you who've worked with weight loss or struggled with it yourself, that, one attempt is not necessarily a long-term habit. It needs to be something that's kind of addressed over a long-term basis. But still, for, it is apparent that a gynecologic oncologist carries a lot of weight here, and it's important for them to be addressing the issue. For those who didn't receive this recommendation from either provider, none of them had a weight loss attempt. So I think, the healthcare providers are really an important kind of gatekeeper here, and changing their behavior so they're at least addressing this issue. We know they're addressing a lot of issues, and that's, particularly in an oncology setting, there are a lot of things to talk about with a patient, but we need to kind of raise the profile of this for cancer providers. And I think ASCO has actually taken an important step in this area. The American Society of Clinical Oncology, which is the big professional organization for oncologists, has for the past couple of years this obesity initiative to increase awareness of the obesity and cancer risk, and also to provide tools and resources to help oncology providers better address obesity in the cancer setting. So that is the end of my presentation, I believe. Yes. So if you have any questions, I'm happy to answer them.
Forgive me if I missed it. I was previously in your methodology. What kind of nutritional counseling or dietary counseling was offered? Because it was, I guess, in essence, sort of a weight loss study, right?
No, it was not a weight loss study. And that's one of the limitations, is we were strictly looking to increase physical activity. And I don't feel too badly about that, because I think even if people aren't losing weight, it's a benefit for them to be more physically active, and they can get health benefits as well as kind of mental health benefits from that. But and the funding announcement that we're responding to was specifically about physical activity, so we had to do that. But I think one of the things we recognize is that women came to the program because they wanted to lose weight, and we did provide them with some resources. And you might want to try Weight Watchers, or here's this website, but we didn't do specifically any nutritional counseling. It was all on physical activity. Yes.
So for the last point, or second to last point you made about the barrier with physicians addressing weight loss, do you know if there's any discussion about referrals to dietitians on the outpatient end? All I can speak from is my pediatrics experience, where that was pretty common to refer you to an RD or the general peds outpatient clinic for that.
So, I can mostly speak to MD Anderson, because that's what I'm most familiar with. And I will say we do have dietitians at MD Anderson, and there's dietitians assigned to all the different centers that are treating different disease sites. But they are, the orientation of oncology dietitians is primarily geared towards helping people manage treatment-related side effects, preventing cachexia, helping them figure out better ways to eat if they have mouth sores or if they have nausea and vomiting, things like that. And so those dietitians are not particularly well oriented towards helping people with weight loss. So
you had hinted at kind of retention, that you didn't really have patients, prolonged, and you said your sample was 100. Did all of them complete pretty much the whole duration of your study?
Well, I wish. So about 78% it completed something, at least one other time point as far as assessments. The adherence to the telephone counseling sessions, I think on average, they did about 70% of the telephone counseling sessions. Yeah, in any intervention like this, engaging people who are not who are losing motivation or running into barriers is the hardest part, because they don't, what the women who are successful would tell us is that the counseling was great because it kept them accountable, and they knew that they were going to have that call every week or every other week, and would, make sure that they were physically active so they could tell it to their coach. But that also meant that when they weren't physically active, they didn't really want to talk to their coach. So it's a challenge in any interventions. Yes.
Could you please comment on current thoughts about how obesity increases the risk for endometrial cancer?
So sure, there's, and I can't comment in a lot of depth, but there's, I can say that the two hypotheses are really real, and they're interrelated, are related to estrogen So with obese women having higher levels of circulating estrogen even after menopause, that sort of increased proliferation in the endometrial lining, and insulin. So those are kind of the two pathways.
Is that, sorry, I
Increasing.
just wanted to clarify, is that the pathway that involves, it's the estrogen and the enzyme?
The aromatase?
Yes.
So yeah, you have to pardon me because I'm the behavioral scientist, so I can't really pin down exactly the mechanisms for you. But yeah, aromatase does, convert testosterone, right, androgens into estrogens, and so that's I would assume that's part of what's operational here.
So what happens to these women if cancer reoccurs? What can kill these women? Is there just a metastasis to all kinds of other parts of the body? Does the primary cancer reoccur?
So the ones who have metastatic disease, or when it recurs, it mostly recurs in people who already have an advanced stage of diagnosis. So stage 1 and stage 2 cancers rarely recur. So the stage 3 cancers might be more likely, so they metastasize. I believe local recurrence is primarily on the peritoneal wall and so forth. So.
And can you just amplify a little bit more about, so what is the protective component here? Maybe this can't be easily dissected. Is it the exercise itself that is creating perhaps some biochemical alteration, maybe estrogen, insulin, whatever, or is it the weight loss? I mean, is there, can you not lose weight but have reduced risk of recurrence or complication? Sure.
So in looking at the prospective studies, looking at endometrial cancer risk, obesity and physical activity in some studies emerge as independent risk factors. So, but in some studies, they're completely confounded. So that's why physical activity is kind of a probable relationship with endometrial cancer. Obesity is very clearly associated, but if you look at in a cohort study at physical activity and how it predicts endometrial cancer risk, and then you control for BMI, sometimes that relationship goes away. In some studies, it's still there. So I think we're not really certain. But physical activity, even in the absence of weight loss, can improve some metabolic risk factors, can improve insulin sensitivity and so forth. So there probably are some effects of that, but I can imagine that in terms of prevention, you're going to see the best effects with exercise and weight loss. Yes.
In your study, did you distinguish between whether the participants completed the program on their own, or did you kind of recognize that they did it with someone else? Because I know that, like, when you do something like this with someone else, it has a pretty big impact on whether or not you can complete it in your self-efficacy as well.
Yeah, so we didn't look at that formally, but we did measure their social support for exercise. And we see a relationship between social support and self-efficacy and physical activity. It tends to go away when you put other variables in the model. So we're not really sure if it's an independent benefit to have good social support, but it does appear, to be related. There's sort of this cluster of things that do appear to be related to better self-efficacy and more physical activity. Yes.
In the study, I forget which postdoc, it was the big slide with all the
boxes?
Yes.
Yeah.
So in that study, or when you do your weight loss interventions, do you account for time of year? Is it rolling admission? Does everyone start at once? I'm wondering if holiday interference has anything to do with why you said that there was that long-term, how you saw more effectiveness in the long term, and I wonder where the holidays played a role, just from what I'm familiar with research that has shown that holiday interference increases your activity.
Yeah. It's a very good point. Yeah. Yeah, here we have a rolling admission. So it's not that everybody, started it's not that everybody started in October and then it wasn't until January that we started seeing some of these relationships or changes. So it was rolling enrollment. But I think it is a good point, and it's something we don't look at enough in our studies, both when we're talking about eating behavior and physical activity behavior, because we know those can be greatly affected by seasonal effects, whether they be holidays or weather. Right now is a great time to go out for a walk, right? August, not so great. Find a mall, right? Especially if you have a BMI of 35, you might not want to be out there when it's a heat index of 105. So I think that's something we don't look at enough. Also, one thing that we're starting to look at more, since we have this daily data, is looking at day of the week. And does self-efficacy have different relationship to physical activity, or outcome expectations for that matter, have a different relationship to physical activity on Saturdays and Sundays versus Wednesdays, versus weekdays. So.
Last question. Go ahead.
Sorry. What was the home environment like for all of the study participants? Were they all kind of in the city or in suburbs? And that would affect if they can get outside and kind of walk around the block.
Yeah, that's a great question, and we don't have really good data on that. I tried to get one of my colleagues, since we had everybody's zip codes, and addresses, I tried to get one of my colleagues who's interested in the built environment to do like a sub-study to really analyze the neighborhoods. And she's like, that really costs a lot of money. That's very complicated if you don't have the database already set up. So, although I think a lot of them lived in the Houston area, and there probably would be a mix of more urban or suburban. But I would say, if you're familiar with Houston, even the more, inside the loop neighborhoods look pretty suburban by most city standards. We don't have, except for right in the downtown area or the medical center area, the Galleria area, kind of a lot of high rise, kind of what we think of as urban neighborhoods. But there could have been women from, kind of poorer, less safe neighborhoods, that kind of thing, and that could enter into it as well.
Okay, well, let's thank Dr. Basen.